working in an orthopedic department, International Medical University. Today I am going to demonstrate the examination of the elbow. The object is how to examine and to find out any good finding. With that help, we can come to a diagnosis. Before going for examination, you need a proper history taking. Then you will get the idea where is the problem, and also to certain extent you can get a good idea what is the patient's problem and diagnosis. For completion sake, you have to do the complete examination of the elbow. And first we will do in a musculoskeletal system like an inspection, that is look, feel, palpation and movement. Sometime we will do some special tests. In the inspection, we want to see how the patient is holding his arm. Sometime if after the injury, the patient may be holding the arm with the other hand, or sometime he will come with the sling. And after completely relaxing, and then expose his elbow and see what is the attitude of the limb. The attitude limb, it may be a flex or it may be extended. Then an inspection, anterior side, the posterior side and the lateral side and medial side. By seeing, you can identify the deformity. Like in the anterior and lateral side, you can see whether there is any flexion deformity or there. Anterior, you can see the deformity whether there is a cubitus valgus or varus, you can see it. And also in the posterior side, you can see the olecranon process and also the olecranon fossa gutters. So another landmark is 3-point bony point. This is called isosceles point triangle. What you have to do, there is a medial epicondyle, the lateral epicondyle, olecranon process. When you flex it in 90 degree, it forms a triangle. When you extend completely, it becomes a straight line. This can be useful if you to find out whether there is a migration of the olecranon upward, example of the superior posterior dislocation. In the inspection, you have to see whether there is a para-olecranon gutter. If there is any infection or inflammation, the joint is swollen, this fossa will be obliterated. If you want to feel for the fossa and the displacement test, you push it one side, the bulge will be you can feel it. This is the displacement test, you can do it. Inspection, in addition to that one, you have to see the muscle wasting. Is there any muscle wasting of the bicep, tricep and forearm muscle? And when coming to the focusing to the elbow, the anterior side whether there is any redness or posterior side any redness or the swelling or scar. Sometimes the patient will come with a old scar of injury or the surgical scar. So now we will go into the palpation. The palpation is a warmth you want to see, and in the anterior side as well as the posterior side, and sometimes you can see in the medial side and the lateral side also. Then after that you palpate to all the bony points. One is a lateral epicondyle, the medial epicondyle and the olecranon process and the radial head. Sometimes radial head will be very difficult. You just palpate just below the lateral epicondyle and feel with the thumb and rotate, pronate and supinate, then you can feel the rotation. And also sometimes you can feel if there is arthritic changes, you can feel the crepitation. Also when you want to feel the crepitation of the elbow, you can feel there is doing the full flexion and extension. And palpation, in addition to that, in the medial epicondyle groove, ulnar nerve is running, you can palpate and roll it down, it will like a cord. Sometimes there may be some abscess in the ulnar nerve. So ulnar nerve, some abscess, you can feel it. And also when you do the rolling out, and you can see the thickness, and also you want to see whether it is subluxating, then you can move the elbow and see whether the ulnar nerve is subluxating or not. In palpation, you can feel the ulnar border. Suppose a old Montague fracture dislocation, malunited, you can feel the thickness, and also if there is a thickness, definitely you want to see whether the radial head is in the correct position or displaced. Third component is the movement. So elbow movement is you can do the one is a flexion and extension. Otherwise, you can call the range of movement the normal range from 0 to 140 to 150 you can do it. And there is sometimes you can have a hyperextension, especially the hyperextension more in the ladies or the people who is having a ligamental laxity. For the supination and pronation, you are actually examining the superior and inferior radioulnar joint. In this joint, you keep the elbow close to the body and in mid-prone position and rotate supination. It will round about 0 to 80 degrees. From here, the supination will be 0 to 80 degrees. For a completion check of elbow examination, there are few special tests you can do it. One is Coulson test, especially the patient when complaining the lateral epicondyle, that is tennis elbow. For a tennis elbow, you can do the Coulson test. This is to elicit the provoke test to elicit the tenderness over the lateral epicondyle. What you have to do is flex the elbow 90 degrees and pronate, give the resistance, then do the extension of the wrist or radial deviation. That time the patient will complain there is a pain in the lateral epicondyle. So the other test you can do for tennis elbow, this test is called chair test. What you have to do is you flex the elbow shoulder 60 degrees and extend the elbow and pronate it completely, and you hold the edge of the shoulder and extend your wrist and lift the chair. That time you will provoking the pain in the lateral epicondyle, and then that is confirming that clinically the tennis elbow. For the next important test is a golfer's elbow. This is quite second common problem in the elbow, and what you have to do is you flex the elbow and 90 degree and supinate against the resistance and extend the wrist and finger, and then give a passive stretching and slowly extend the elbow. Then the patient will complain the pain in the medial side of the epicondyle. This is showing, it is giving evidence that is test is positive, means golfer's elbow. So now you can do another special test is whether the collateral ligament, the medial collateral and lateral collateral, whether there is injury or rupture, you can demonstrate by doing the stress test. This is, we called it valgus stress and varus test, cubitus valgus and cubitus varus. So what you have to do is unlock the elbow by doing this some few degrees of flexion and stabilize the elbow and give the valgus strain to stretch the medial collateral ligament. If the patient is complaining a pain or it is moving towards excessive towards the valgus, that means the medial collateral ligament injury. For a lateral collateral ligament injury, what the same thing, you have to unlock the elbow and then give the varus strain, and then you see whether there is a pain is elicited or whether it is the forearm is moving varus. That we can consider there may be instability of the collateral ligament, lateral collateral ligament. Next is instability anterior and posterior, especially the posterior. What you can do is hold the humerus arm and the forearm, flex in the 90 degrees and give the posterior push, then pull it. Then if there is instability, you can find out there is a instability. This can be due to the ligamental laxity or old posterior dislocation. It may be moving up and down. As a completion, you have to do the neurovascular examination. So this one is you feel for the brachial pulse. just below the medial to the tendon, bicep tendon, then radial artery, ulnar artery, and capillary circulation. So this will give an idea a good circulation, because due to the injury, the elbow injury, the vessel may be involved and also can be nerve involved. So we have to examine the nerve also separately. There are 3 nerves are coming. One is a median nerve, ulnar nerve, and radial nerve. So in the nerve examination, it is not necessary to examine the individual muscle. Even the important muscle for each nerve, if you examine, that is more than enough. For a median nerve, you show the OK sign. If he is doing the OK sign, that means his opponent is working, that means the median nerve is intact. And also you can check whether there is a sensation, is a 3.5 fingers is present by touching the cotton wool. And other nerve is a ulnar nerve. Ulnar nerve is this sensation you can find out in the 1.5 finger in the medial side. And also what you can do is the main function, one of the muscle is intraosseous, dorsal intraosseous and palmar intraosseous. Ask the patient to open the fingers and close it, or otherwise ask him to give a resisted movement. Third nerve is your radial nerve. The radial nerve sensation you can check it in the first web space near the thumb. And also for the motor function, you ask the patient to extend the wrist and extend the finger. If he is able to do, that means his radial nerve is intact. This is the 3 nerves. You just quickly examine, say whether this is any complication due to the fracture or disease happen into the nerves, you can find out. With a good history and physical examination, as I told, in the inspection, palpation and movement and the special test, you can identify a correct proper diagnosis. Then after that you can do the investigation to confirm your diagnosis.